the SNA, suppose the student have completed their student period, 4 years or 3 years of your degree, diploma courses or 4 years of your degree courses, automatically it will convert it to Trained Nurses Association of India. So with this, so you have all the eligibility to have your professional enhancement. For example, if you want to have your presentation, scientific paper presentation or publication, and whatever your activities are there, and you can have the abroad opportunity also through the TNA headquarters. So we'll have, so every month you'll get receive a like a bulletin, TNA bulletin in your registered number. So with this, you can grow throughout your nursing profession. So in this, we can find and you can able to learn from India, out of India, foreign countries also, what all the activities are happening in the nursing field. So like lot of things you can able to find. So you please find the importance of SNA and TNA unit. And with this, we are having the collaboration with the academic performance, as well as 2 months before we have the sports activities also. So all the students, you're actively participating all the programs. So I'm so happy to have it a part of SNA and TNA unit in Rajasthan. So once again, I am giving the small introduction for our chief guest. Sir, Dr. Jogendra Sharma ji is a president of TNA Rajasthan State Branch, vice president of Indian Nursing Council, New Delhi, principal of SMS Government College of Nursing, Jaipur, and former Dean of RUHS, Rajasthan, former Registrar, RNC, Rajasthan. So we can wait for small duration. Sir will add in the Zoom and Sir will give a small speech to encouraging with the encouraging words. So please stay tuned.
Hello, everybody. Sorry for the inconvenience, but now the wait is over and our honorable chief guest is present among us. He is not just a great personality, but an eminent nursing tutor and researcher. So his achievements is beyond the measures we cannot explain in the words. Now I would like to hand over the call to Sir so that he can share his words of wisdom with us and encourage us about our profession. So huge round of applause for our chief guest, Mr. Jogender Sir. Sir, please join us.
मैम मेरा म्यूट तो उठाइए पहले प्लीज। हेलो 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 हेलो। मैम मीटिंग में इनवाइट किया है तो म्यूट तो हटा देना मेरे पहले। हेलो हेलो, आवाज आ रही है मेरी?
यस सर।
यस सर।
ठीक है। एसएन नर्सिंग कॉलेज श्री गंगानगर और टीएनआई ब्रांच राजस्थान द्वारा आयोजित इस मेनोपॉजल हेल्थ के महत्वपूर्ण विषय पर वेबिनार का जो आयोजन किया, आयोजनकर्ता एसएन नर्सिंग कॉलेज की ऊर्जावान डायनेमिक हिंदुस्तान में एकेडमिक रूप में अपना नाम पहचान रखने वाली डॉक्टर जासमीन संथा जी, वाइस प्रिंसिपल शक्ति सिंह जी सोनी जी, टीएनआई सेक्रेटरी डॉक्टर व्यास जी, एसएनएस सेक्रेटरी ईशा देव कौर जी और सभी एसएन नर्सिंग कॉलेज से जुड़े फैकल्टीगण, सभी छात्र छात्राएं, सुदूर राजस्थान के कोने कोने से जुड़े इस वेबिनार में सभी नर्सिंग प्रोफेशनल्स, मैं धन्यवाद देना चाहूंगा टीएनआई राजस्थान ब्रांच के आह्वान पर। जिस प्रकार से एक श्रृंखला लगी है पूरे राजस्थान में वेबिनार्स की, उसी श्रृंखला में आज आपने इस आयोजन को करके छात्र छात्राओं को, फैकल्टी को एक ऐसे महत्वपूर्ण विषय पर पहचान देने की कोशिश की लोग किताबों में पढ़ते हैं, सब रहता है, पर जो आपसी संवाद के बाद सीखने को मिलता है और जो रिसोर्स पर्सन उसमें डाटा कलेक्शन स्पेशली करते हैं, उसका लाभ सभी नर्सिंग प्रोफेशनल्स को मिलता है। आज म्यूट कर लें प्लीज जो बोल रहे हैं। आज कोविड के बाद जिस प्रकार से वेबिनार के माध्यम से दुनिया के किसी कोने में बैठे हों, हम कार्यशालाओं के माध्यम से महत्वपूर्ण विषयों पर ये वेबिनार आयोजित कर उस कॉन्फ्रेंस जो इतनी सारी करी नहीं जा सकती फिजिकल, उसका एक छोटा रूप के रूप में निरंतर हम संपर्क में रहते हैं और जो समसामयिक विषय नर्सिंग प्रोफेशनल्स में आते रहते हैं उसके बारे में बात करते रहते हैं। आज के विषय में एक्सपर्ट्स आए हुए हैं, रिसोर्स पर्सन आपके पास हैं। मैं बस इतना ही कहना चाहूंगा, ये मेनोपॉज कोई बीमारी नहीं है, ये जीवन के चक्र का एक पहलू है। बच्चे पैदा होते हैं, बड़े होते हैं और उम्र की तरफ बढ़ते हैं। उसी प्रकार से इस प्रकार की कोई भी एक रेगुलर जो कि एज के बाद आना लाजमी है, परंतु उसको एक भय मुक्त वातावरण करना चाहिए। हम नर्सिंग प्रोफेशनल उसके बारे में जानते हैं। हमें जनता में जाके, जिस मोहल्ले गली में हम रहते हैं, जहां हम जॉब करते हैं, जो जो हमारे संवादों में आते हैं, उनको अपने सकारात्मक ज्ञान से, जो आपने ऑथेंटिक ज्ञान बुक्स और रिसर्च के माध्यम से पढ़ा और देखा है, उसको प्रचार प्रसार करना चाहिए। आज जो किंवदंती पुराने जमाने की बन गई थी, उन किंवदंतियों से दूर निकलकर जब देश के यशस्वी प्रधानमंत्री जी विकसित भारत का नारा देकर 2047 तक इस देश को पर नंबर 1 पर लाने का सपना सजोए बैठे हैं, हम हमें उनके हाथ मजबूत करते हुए इस नर्सिंग प्रोफेशनल में किस प्रकार से शिक्षा का ज्ञान प्रचार प्रसार हो, उसमें योगदान देना चाहिए। आज जुड़े पार्टिसिपेंट में मैं उनको विशेष रूप से धन्यवाद देता हूं। मैं ऑब्जर्व करता हूं हर वेबिनार को, कौन कौन लोग, कितने लोग जुड़े हैं, कब तक जुड़े हैं, कितनी देर तक जुड़े हैं। वो अपने खुद के ज्ञान के साथ साथ, चूंकि टीचिंग में है और एक छात्र छात्रा बनने के बाद आगे एक सामाजिक नर्सिंग जीवन में आएंगे, तो इनका निश्चित रूप से इस ज्ञान का प्रचार प्रसार करेंगे। जो निरंतर इन वेबिनार्स को ज्वाइन कर रहे हैं, मैं उनको बहुत बहुत धन्यवाद देता हूं कि आप एक प्लानिंग वर्कर TNI के द्वारा आयोजित वेबिनार्स में अपना समय और योगदान दे रहे हैं, साथ ही साथ अपने इतने महत्वपूर्ण विषय पर अपना ज्ञान भी बढ़ा रहे हैं। मैं ज्यादा समय नहीं लेते हुए डॉक्टर जासमिन जी को धन्यवाद देता हूं कि निश्चित रूप से जब से आप राजस्थान में आए हैं, आपकी कड़ी मेहनत और आपका जो सोच और ज्ञान है, और जिस प्रकार से PhD के आप गाइड हैं, आपने नॉलेज के आधार पर इस राजस्थान में विशेष रूप से गंगानगर के क्षेत्र में नर्सिंग में प्रोफेशनल्स में एक नया कीर्तिमान स्थापित किया है। मैं सोचता हूं आगे आप स्वयं अपने ज्ञान के साथ साथ ऐसे नर्सिंग कॉलेज के सभी फैकल्टी, छात्र छात्राएं इस नर्सिंग प्रोफेशनल्स को आगे बढ़ाने में अपना विशेष योगदान अनवरत जारी रखेंगे। मैं अपनी बात ये सब कहते हुए विराम देता हूं। जय हिंद, जय भारत, जय नर्सेज।
Thank you so much, sir, for your precious time and valuable words, which encourage us to be a better person in future like you. We are many inspired of you. So now, moving further in our seminar, we are at a point for what purpose this webinar is. its learning and knowledge. So for this, it's time for our session first about concepts and types of menopausal health. For this session, we are honored to have esteemed speaker Dr. Sarita Rawat, whose accomplishments are being shockful to me even, that she has completed her BSc Honours in Nursing from Ahilya Bai College of Nursing University, Delhi, followed by her MSc Nursing specialized in obstetrics and gynecology, and now pursuing her PhD from NINA PGIMER, Chandigarh. She has been serving as a nursing tutor in National Institute of Nursing Education, Chandigarh, since 2013. It has been almost 15 years of teaching experience. Her academic contributions include chapter in 9 clinic nursing procedure, published by CBC Publishers and Distribution. She is also member of several professional nursing organizations and contributed significantly with more than 10 original research articles in high index journals. So ma'am, we warmly welcome you to our webinar, and huge round of applause for Dr.
Thank you so much for lovely introduction. Am I audible? Am I audible?
Yes, ma'am, you're audible.
Oh. So a very good morning to all of you. Respected principal ma'am, esteemed dignitaries and distinguished speakers and respected faculty members and my dear participants. So it is a great honor and privilege for me for the speaker in today's international webinar on menopausal health. So today I will speak on concept and types of menopause.
अमनदीप नाम से एक बच्ची है फोर्थ सेमेस्टर
Can you please slide share?
अमनदीप ये कोई सी की बेस में
So before starting the topic, as we know, menopause is not a disease. It is a natural and significant transition in every woman's life. So from today presentation outline, we will discuss the concept to care. So what we will discuss, first we'll discuss the burden of menopause on the family, individual, workplace, health system and societal dimensions. Then we'll discuss the perspective of major professional societies which are working for menopausal women. Then we'll discuss the concept, terminology in menopause, what are the stages and types of menopause. Then we'll briefly discuss the reproductive aging and menopausal transition. What are the hormonal and physiological changes in menopause? Then the clinical features due to the menopause, how to diagnose them, what are the red flags in the menopause, and healthy menopause lifestyle prevention, and what are the nursing priorities we can work on menopausal women. Then health teaching, how to communicate with them, what are the myths regarding menopause, and how we can solve these or taking a decision involving the mother also or menopausal women. Then take home message. Please change the slide. So now why it is important to learn about the menopause. So first we'll discuss the menopausal burden, we can say. So menopause is normal biological transition, but its symptoms can be substantial and highly variable. Highly variable, we can say it is vary from individual to individual. So physical burden, we can say the vasomotor symptoms. So what are the vasomotor symptoms? Commonly mood swings and night sweats, sleep disturbance may be there, genitourinary symptoms, sexual difficulty, and musculoskeletal complaints are women experience. Then psychological and cognitive burden, we can say mood swings, anxiety, irritability, concentration difficulty, and reduced well-being in some women. So long-term health consideration, as we know that menopause will affect the bone health of a woman. It also risks the cardiovascular and metabolic health and healthy aging. If we talk about the social burden, we cannot openly express our menopausal symptoms, or we can say it is a stigma, misinformation, limited family and community discussions, and unequal access to care. So, workplace burden, if women is working, then she's symptoms may affect the comfort, productivity of her work, attendance, job satisfaction, and retention, especially when the workplace conditions are unsupportive. Next, please. So, according to WHO perspective, WHO described that the menopause are as an under-recognized and under-supported phase of the women health. So, symptoms can affect well-being and daily functioning, which we have also discussed in previous slide. So, perimenopausal and postmenopausal experience may affect the physical, emotional, mental, and social well-being. So, WHO framed menopause within a life course approach and healthy aging and health equality, dignity, and human rights. So it emphasized, the WHO emphasized strong evidence and health worker training, awareness services, and health universal health coverage approaches. Next, please. Can you please slide show? So next we'll talk about the menopause society. So in India, we are having so many societies, international and national societies, which are working for the menopausal society. So the menopausal society basically highlight or highly variable symptoms experience. Some women have a few symptoms while the other experience moderate to severe. So symptoms may adversely affect the quality of life, relationship, job satisfaction, and career advancement. Public health journey, prevention of long-term morbidity, and tired care. So tired care here is the care given primary care, secondary care, or tertiary care. And they also focus on the workforce support and health system implementation. Next, please. So here we are having an International Menopause Society, and it also frames the menopause within a women midlife health and health aging rather than the symptom treatment alone. So they basically recommend the overall lifestyle and body changes, vasomotor symptoms and genitourinary syndrome, cardiometabolic health, bone health, cancers, cognition and premature ovarian insufficiency, and sexual well-being. So, International Menopause Society recommend are intended as a current global blueprint for midlife health and menopause management. Next, please. Now we talk about the Indian Menopause Society, which is in Surat, Gujarat. So, the Dr. Sudha Sharma is the president recently. So the Indian Menopausal Society is a multidisciplinary national society established in 1995, basically focusing on comprehensive well-being of a mature and elderly Indian women. So in 2016, the Indian Menopause Society clinically practiced the guideline or addressed the menopause in an Indian context and provide broad recommendation for a clinical care. It also recognized the menopause and workplace, an important area of midlife health. Guideline estimate million of Indian women aged equal or over than 40 years are working, and it care should be integrated. Symptoms relief, prevention, counseling should be there, lifestyle changes, bone and cardiovascular health, and culturally appropriate support provided by the society. Here is the British Menopause Society. So it is also guide or emphasize on the safe and evidence-based menopausal care, and clinical education is also important. So the British Menopause Society is joint professional statement with the Indian International Menopausal Society, European Menopausal and Andropause Society, or RCOG guideline, which we follow in midwifery, and other organization on the major menopausal societies issue. So, in the recommendation by the British Menopause, the teaching implications include nurse and health professional need competence in recognizing the symptoms, how to communicate, or addressing the misconceptions, and signposting or referring appropriately. Next, please. So this is the summary of what we have, the perspective of different societies we have, according to WHO, International Midwifery Society, Indian Menopausal Society, sorry, and European Menopausal Society or British Menopausal Society. Basically, they all focus on the women's public health, equity, care, or life course health, dignity, accessory, and workforce impact. Next, please. So now we'll discuss the first, previous we have discussed the burden, why it is important to learn about menopause. Now we'll discuss the concept, core concept. So menopause means when it occurs and how it fit into the life course. Next. So menopause is a biological process life stage making the permanent end of menstruation due to the loss of ovarian follicular activity. So it usually or naturally between, or we can say it is the average age of menopause is 45 to 55 years. So natural menopause is diagnosed retrospectively after 12 executive months without menstruation when no other causes explain the amenorrhea. Next, please. So why does menopause happen? Or what are the factors that contributing to menopause? So in this, it includes the follicular reverse decline with age, ovulation become less consistent, and ovarian hormone production changes, and symptoms and their intensity is varying between the individual, or it can vary individual to individual. Next, please. So, menopause is not just a period stopping. Basically, it is a reproductive milestone. So, the transition can influence the multiple domain of health, and it include the changes in the reproductive, menstrual and reproductive changes. Vasomotor symptoms will be there, the hot flushes and night sweat, mood swings, sleep disturbance, cognitive complaint, genitourinary and sexual symptoms. And it also lead to musculoskeletal and long-term health problems. Next, please. So, what is the difference between menopause versus climacterics? Basically, the terms are related, but they are not interchangeable. Menopause is a specific reproductive milestone, and climacteric basically it is a broad transition from reproductive to non-reproductive life. In this, we can also term used as perimenopause. So basically, it is a transition before menopause plus first year after the final menstrual cycle. And what is postmenopause? It is a period after the menopause. Next, please. So, in if we learn about when we study the menopause, there are other terminologies we use in teaching or documenting or when we are counseling the patient. So, premenopause, it is a reproductive year, years before the menopausal transition or changes which are happening after menopause. Perimenopause, basically, it is a transitional period around the final menstrual period. And what is menopause? It is a retrospectively identified final menstrual period. Post is a year following the menopause, and climacteric, we are using a broad life course transition from reproduction to the non-reproductive. Please unmute, sorry, mute yourself. So this is the journey of menopause from reproduction, then the transition period where the changes in the cycle happens, then for 12 months of amenorrhea we call it menopause, and after menopause the postmenopause. Next slide, please. So, the transition period or after menopause, the final menstrual period. So, the exact date of final menstrual period is known only retrospectively. So, a woman may have an irregular cycle for a month or year before the final menstrual period. So, 12 consecutive months without menstruation is the conventional clinical marker of a natural menopause when other causes are excluded. So, bleeding after established menopause indicate the clinical assessment. So, the stages of reproductive aging, understanding the transition from a regular cycle to the postmenopausal cycles. So, we'll discuss the stages, reproductive stage. So, reproductive aging is a continuum rather than a single event. It takes a time. So, early reproductive year, then it lead to the late reproductive menopausal transition where 12 months amenorrhea happens, and then the postmenopausal. So cycle variability often increases before menstruation stop, and symptoms may begin during the transition, not only after the final menstrual period. So perimenopause, it describes the period around the menopause transition, often begin with change in the menstrual cycle pattern. If the cycle is normal, will be changing, and the mother will, women will feeling the hot flush, night sweats may be emerges, sleep and mood changes may be there, fertility decline, but pregnancy remain possible until the menopause is established. Next, please. So, early menopausal transition. So, the cycle become persistently different from previous pattern. Ovulation it become less predictable, and symptom may be absent, mild or prominent. It depend upon individual to individual. Next, please. So, late menopausal transition, the long interval between the period become more common. Here, the vasomotor symptoms are become more frequent. And what are the vasomotor symptoms? Hot flushes and night sweats. Sleep disturbance and mood disturbance may be more noticeable during the late menopause, and pregnancy is still possible until the menopause is confirmed. So, in postmenopause begin after the final menstrual period. Here, the ovarian estrogen production remain the low. Some symptoms improve and other may be persist. Genitourinary systems symptom can become more prominent over the time, and bone, cardiovascular and metabolic health become important part of a healthy aging. So proper screening should be there in postmenopause women. So this is the stages we have discussed, from reproductive, then the early transition where the menstrual cycle changes, late transition there will be the long gap between the menstruation cycle and the final menstrual period, the 12-month marker, and last is the postmenopausal or long-term health. Next please. So why the stages matter clinically? Okay, how we can diagnose it a menopause? So at the age of 45 or more than 45, typically a premenopausal or menopause is usually a clinical diagnosis. So at young ages, earlier menopause or premature ovarian insufficiency need consideration. Hormonal contraception can mask menstrual pattern, and hysterectomy can remove the menstrual marker of the menopause. So next we'll discuss after the type of stages of menopause. Now the types of menopause. So classified menopause by time and due to the cause. So major type of menopause, it include natural or spontaneous menopause, early menopause before the age of 40, premature ovarian insufficiency under 40 years, surgical menopause or medical menopause, and other treatment related or induced menopause. So we will discuss one by one. So first type is natural menopause. So natural menopause occurs without a medical or surgical intervention causing the ovarian failure. It usually occur between age of 45 to 55 years. It reflects the age-related loss of the ovarian follicular function and often preceded by the premenopause. Second is the early menopause. So it may occur naturally or treatment related, can affect the fertility, emotional well-being, and psychological support is very important to diagnose, and assessment should be considered on the individual basis. And the causes. Third is the premature ovarian in follicular ovarian insufficiency. Basically, it is present with irregular or absent period or menopausal symptoms. Cause maybe include genetic, autoimmune disease if mother is having, treatment related or unknown factor. So, specialist reproductive and menopause input may be appropriate, and diagnosis is on the basis of clinical assessment rather than assuming the age related menopause. Next is the surgical menopause. So the onset can be sudden or rather than gradual. Symptom may be abrupt or more intense for individual. If the uterus remain, the progesterone may be needed for systematic estrogen. So the management is individual according to age, symptom, and contraindication. So in surgical menopause, it is due to the hysterectomy or removal of ovaries. It lead to surgical menopause. Next is medical menopause. So the medical intervention can suppress or damage the ovarian function. It lead to menopause. Due to the chemotherapy may repair the ovarian function. Pelvic radiation can damage the ovarian tissue, and some medicine intentionally suppress the ovarian activities. So menstrual cessation may be temporary or permanent depending upon the cause. So here we do the comparison between induced or natural. So natural is related to the age-related decline in ovarian function. Surgical is procedure directly remove the ovarian function. So medical is the treatment suppress or damage the ovarian function. And health and fertility implication can differ by age or reversibility. So these are the a quick revision of types of. So there are natural, early, and premature ovarian insufficiency, surgical or medical menopause. So these are the hormonal and physiological concepts you will discuss in upcoming sessions. Slide please. So this is the overview I have covered. Next slide please. This all you will discuss in upcoming sessions. What are the changes, symptoms of menopause? Next. Next please. Next. So menopause and fertility. So ovulation can still occur during premenopause. So contraception is the important, remain important until the menopause is established according to the appropriate guidance. So fertility counseling should be individualized. Next, please. Next. From starting of the first my slides, we are discussing what are most vasomotor symptoms. So these are sudden sensation of heat, sweating, and flushing may occur. Palpitation or anxiety may experience, and night sweat can disturb the sleep and daytime function of a woman. Sleep changes, difficulty in falling asleep, night walking, early morning awakening, daytime fatigue, and reduced concentration on the work, and address both sleep hygiene and underlying symptoms. In mood swings or cognitive symptoms, it include irritability or low mood, anxiety symptoms, reduce concentration, or we can say brain fog, change in the confidence, and consider other causes when symptoms are severe, persist, or atypical. The women also experience genitourinary symptoms, which include vaginal dryness, discomfort, burning and irritation, dyspareunia, and urinary urgency or recurrent urinary symptoms. And in musculoskeletal system, they feel aches and stiffness may be reported. Muscles strengthening and physical activity increases. Resistance exercise supporting healthy aging, and persistent or severe symptoms require assessment for the other causes also. Sexual health changes occur during menopause is desire may be changed, vaginal dryness can contribute to discomfort, sleep, mood, relationship factors, and medication may contribute, and use sensitive and not judgmental communication. So, how to diagnose or how to assess the menopausal women? So, history taking or clinical assessment play an important role. Next, please. So according to these phases, the current NICE guideline emphasize on the clinical identification. So otherwise healthy people is 45 or with the typical symptoms. According to the clinical symptoms, we will assess. All laboratory confirmation is unnecessary in these groups. Perimenopausal. So when laboratory tests done, basically we consider the FSH when women is suspected at the age of 40 to 45 with symptoms and in change in the cycle. FSS is also used in assessment of suspected premature ovarian insufficiency under 40 years and do not interrupt one value without clinical contest. So other differential diagnosis can be there for menopause. The symptoms can vary in pregnancy also. Thyroid disorder can be there, anemia or other systemic illness, medication effect can be there, mood disorders or gynecological condition causing abnormal bleeding. So, what are the red flags? When to refer or investigate? So, the red flags include postmenopausal bleeding need assessment, very heavy or prolonged bleeding need evaluation, new focal pelvic symptom warrant review, and unexplained weight loss is there, severe pain or systemic symptoms need appropriate investigations. So, these are the red flags. So, now the healthy menopause and nursing focus. So the menopause as a life course opportunities, and here the promote physical activity and muscle strengthening can be there. The support the healthy weight and nutrition, address the cardiovascular risk factor as they are more in the postmenopausal women, protect the bone health, support sleep, mental well-being, and sexual health. So these are the nursing assessment part on which we have to work or while giving health teaching to the mother. So first domain include the symptoms as symptoms include the hot flushes, night sweats. So what the women can do or how she can uh, reduce her symptoms. Then we have to focus on the functions, activity of daily living, sleep quality को कैसे improve करना है, what are the concentration, family role क्या रहेगा and work performance. Next is the long term health issues. So there are bone health issues, cardiovascular, metabolic health and health aging. Psychological, psychosocial context, we talk about stigma, relationship, body imaging, cultural beliefs are there, emotional well-being. Then how to assess them, health literacy, affordability, train the providers, and workplace or community support required. So, in sixth domain, the preference is basically making the goals. Treatment preference should be very individual to individual concern. What are the contraindications and share the decision making. Include the women also in decisions. So, our nursing assessment priorities should focus on symptoms and impact on the daily life, menstrual, reproductive history, sleep and mental well-being, genitourinary and sexual health, bone and cardiovascular risk factors, and treatment preference and what are the various during the uh, treatment. So, how to communicate or what are the principles, communication principles? So, menopause conversation should be respectful and individualized or stigma free. Normalize the transition without minimizing the symptoms. Use clear and non judgmental language and ask what matter most to the person. Discuss the options and preferences and encourage questions and share the decision making. So, what are the common myths and facts of menopause? So, myths: menopause is disease, but fact it is normal biological transition. Every woman has severe symptom, but fact is the experiences vary widely. It depends individual to individual. Pregnancy is impossible immediately after the first irregular period, but ovulation can still occur. So, next myth is one FSS test diagnosed the menopause at any age. No, the interpretation depend on age and the symptom or context. So menopause and the contraception is very important. So irregular period do not automatically means infertility. Ovulation can still occur during premenopause. So contraception should be discussed according to age, symptom and methods. Hormonal contraception can alter or mask the bleeding pattern. Individual advice using the current contraceptive guidelines. Next please. So, in menopause, bone health, as healthy aging include productive bone and muscles. So, we have to focus on estrogen decline is associated with accelerated bone loss around the menopause. So, weight bearing and resistance exercise are important. Assess fracture risk according to age and clinical risk factors. Nutrition and vitamin D and calcium advice should be individualized. And in cardiovascular health, assess the blood pressure, weight, activity, if whether the mother is smoking, women is smoking or not, metabolic risk, encourage regular physical activities and healthy diet. Do not assume every mid-life symptom is a menopause. Use individualized risk assessment rather than the age alone. So, at the last, the take-home message from my presentation is the menopause is a specific milestone within a longer transition. So natural menopause usually occur between 45 to 55 years. Types include natural, early, premature ovarian insufficiency, surgical or medical. Diagnosis often clinical in typical cases at or greater than 45 years age. So our treatment or health teaching should be individualized. Personal center care is essential. We are celebrating World Menopausal Day every 18th October yearly. So the latest theme of the World Menopause Day is chronic pain in midlife. Next please. So these are my references. Thank you so much.
Thank you so much, ma'am, for your valuable knowledge. What an insightful and learning session you have taken. Now, I hope that students would be much more clear about the menopause health, that what is menopause health, what are its types, concepts. I think so that before this session, we all would be unaware about this topic, and now our knowledge have been enhanced. One thing I would like to mention to you all, that please pay attention in the sessions very carefully, because at the end of the sessions, we are going to have a post test in which your knowledge will be calculated, that how effectively you have learned from these sessions. So further doing delay, moving forward, we are having our session 2, a step deeper into the knowledge of menopausal health. Like in the session 1, Dr. Sarita ma'am has told us about the concepts and types of menopausal health. One step deeper, now we will learn endocrine and organ changes during this menopausal health. For this session, among us, we are having Professor Manpreet Kaur, who brings with her nearby 12 years of nursing experience, not in teaching, in research, and many more different branches. So here we have before ma'am join us for the session, here is a brief about what qualifications and achievements she had great in her journey of nursing teaching. She has completed her MSc Nursing with specialized in obstetrics and gynecology and recently completed her PhD in nursing from Deshbhakt University. Her research focused on visual teaching method regarding postnatal care. Along with her teaching and research work, she has also taken active responsibilities in student educational development activities, nursing research, quality assurance, and institutional committees. It's a very, very privilege to have her among us for this session. So, ma'am, please join us.
Okay. My name is Manpreet Kaur. Now we are discuss about of the organ changes during the menopause. First of all, we are discuss about of the what is menopause. The menopause is a natural stage of the Aries. Okay, now we are start. In natural biological processes, making the permanent end of the woman menstrual cycle and reproductive activities. This is mostly occur in the age of the 45 to 55 years, and the result of the gradually decline of the ovarian functions and significant reduction of the estrogen and progesterone productions. First of all, we are discuss about of the what are the objective we are specifically learning in the menopause. Knowing the what is a menopause, now we are explain the what is a menopause. Menopause is a permanent cease in the menstrual cycle during the age of 45 to 55 years. And then we are discuss about of the what are the phases of the menopause. Phases of the menopause. First of all, we are discuss about the premenstrual menopause. They are being the several years before menopause, ovarian gradually produce the less estrogen characterized by the irregular period and hot flashes, mood changes. Then we are discuss about of the menopause. Menopause is the official start to the 12 month after the last period of the ovarian function sees the completely and estrogen and progesterone level drop to sharply. In this condition, the estrogen and progesterone level will be decreased. Then post-menopause, the years of the following the menopause symptom may be is but health risk such as a osteoporosis and heart disease increase the significant. Now we are discuss about the next topic related to menopause. The cause of the menopause. Natural aging. The most common biological cause is a natural aging. First of all, I am saying that which is the menopause occur after the 40 years or 55 years. This is a natural age. Sometimes is a surgical reason. There the some surgeries done by the doctors. Any problem like ovaries, that time remove the ovary, that time also menopause occur. Next is a medical treatment. Medical treatment, chemotherapy, radiation therapy, in this condition also occur the menopause. And now we are discuss about the primary and ovarian insufficiency. This is a leading the early menopause before the age of 40. This occur the mostly of the age of the 40. This due to the sometime the hereditary reason, because of the mother also come in the 40-year age of the menopause, and like same next daughter also 45 years or 40 years menopause occur. Now we are discuss of the common symptom which are the when the menopause occur, and which are the symptoms is due to the menopause. Hot flashes, night sweating, when the person is sitting, and sometimes hot flashes continuously, and night sweating. When the nighttime sleep, that time night sweating more occur. And vaginal dryness. Why are vaginal dryness occur? Because of the lubricant decrease the secretion of the vaginal lubricants. That's why the vaginal dryness occur, and discomfort during the intercourse. And the mood swing, irritability, or depression. When the person feeling the hot flashes like that, then mood changes also occur, like irritability, depression, fatigue, sleep disturbance, irregular period, leading to the season. And they are the thinning the hair. Due to the menopause, also thin the hair and dry skin. Skin changes also occur because of the oil production will be decreased, and weight gain. And due to the menopause, also symptoms seen in the weight gain. And then systematic organ changes. Now we are discuss about of the systematic organ changes which are occur. The menopause induce the significant physiological changes across the reproductive. First of all, we are discuss about of the reproductive system. Reproductive system, uterus, ovarian. Uterus become febrile due to the atrophy of the muscle and after menopause. mostly seen in the females after the season of the menopause. Provide will be occur after the menopause. Okay. Next, cervix. In the cervix, also many changes occur. Shrink and appear the flesh with the vagina. And older women may be impossible to identify the separator from the vagina. They not identify the because of the muscle tone become less due to the less muscle tone. They not identify older women. So this is cervix, so this is vagina, like a same thing. Now we are discuss about of the discharge decrease. Vaginal and cervical discharge in the amount of the litter disappear completely. And ovarian smaller and shivering in appears. They become being of the production of the estrogen and increase the amount of the compared to the reproductive years. With the help of the diagram, I am showing the what are the changes in the like ovarian and uterus, cervix also decrease the discharge. Now we are discuss about of the reproductive system in the vagina and vulva. Vaginal changes. There are vaginal many changes occur in the mucous membrane become thin and lost the rigidity after the menopause. After the menopause, there the loss of the muscle tone and the rigidity of the vaginal area and decreases secretion make the vaginal dry, which can be make the sexual intercourse pain and difficult. When the person is doing the sex and that time the painful sex intercourse is occur. There changes in the increase the chronic irritation and infection. Due to the dryness, there the many infections occur like ulcer formation, and sometimes the infection also occur in the vulva or external organ. Fat in the labia majora and the menopause decrease the pubic hair become the spare tissue of the labia minora, clitoris, urethra thin out due to the loss of the muscle tone, and localized thinning the tracting contribute dryness in the increase the likelihood of the urinary tract infection. Mostly when the menopause occur that time always the urinary tract infection occur in the females. That's why we are showing the some old females when the decrease the muscle tone that time occur in the most febrile and uterine prolapse occur in the these conditions. Next we are discuss about the loss of the muscle tone in the pelvic support. In the structural weakness, due to the muscle changes in the skeletal system with the aging and hormone shifting, there is a decrease the amount of the muscle connective tissue and including the ligament support in the bladder. First of all, I'm discuss about of the uterine prolapse. Same like this, because of the ligament support will be decreased to the bladder, uterus, vagina, and rectum. They affect the organ may be loss to support the potentially prolapse, causing the feeling of the severe pelvic pressure on the fullness. Then function impact. When a prolapse occur, then what are the changes in the function? Prolapse can be caused the bulging, the opening of the vagina. The vaginal opening is not proper open because of the bulging due to the prolapse, and leading the difficult in the urination and loss of the control of the urination and bowel movement. Leading the difficulty urination. Due to the prolapse, they cannot be pass the properly urine because of the incontinence of urine, like drop by drop urine occur because of the pressure on the bladder of the uterus. And women who have not children, they high risk of the sportive of the tissue problems, decrease the sex desire, pain during the sexual activity, and common secondary effect. When the decrease the lubricant, they are decrease the desire to the sexual activity and the common secondary effect. And a loss of the muscle tone there the many changes I'm discuss about of the like prolapse of the uterus and due to the prolapse there the pressure on the uterus there drop by drop urine occur and person not feeling well. Now we are changes about the breast and urinary system changes. Breast tissue changes because of the less estrogen stimuli duct the breast decrease the overall size. Uh, in the breast many changes occur because of the estrogen level will be decreased stimulate the milk duct there breast decrease the overall size there size will be decreased the connective tissue support the breast and because of the connective tissue is not supporting well the breast that because of the this tissue is a decrease they diminishing contribute of the prominent changes in the breast shape and fibrous tissue within the breast gradually replace the fat, making of the breast feel like film. When we touch the breast like film. Next, urinary system. What are the changes in the urinary system? Bladder and urethra. There, the loss of the estrogen directly affect of the tone and elasticity of the urinary tissue. The loss of the structure in the contribute to urinary incontinence, loss of the control. The female not control the urine. They passing the urine. Many person in the region, the most of the hospitals they are saying females and not control old females mostly because of the menopause is they are saying I'm not properly pass the urine incontinence urine drop by drop urine increase the urinary frequency in the 1 hour passing the more time urine the high risk of the developing the urinary tract because of the their area is a most more time wet that time is a risk of the urinary tract infection. Then we are discuss about the skeleton system and bone health. Estrogen is a mainly is a bone density. Mostly we are seeing the persons in the old age is a many health issues related the skeleton system like backache and knee problems and most of the females saying I'm not when we are testing that their calcium level will be decreased and most of the estrogen is a mainly bone density and due to the estrogen density will be occurred and decline the level of the rapidly the bone health properly bony health is not well after the menopause bone is not proper reabsorb the exceed bone formation women can be lost the 20% their bone mass in the age of the menopause females is a 20% bone mass will be 5 to 7 years after the menopause. 20% loss the bone mass with the trim of the 7 when menopause occur after the 5 to 7 year of the menopause the rapidly thinning the making the bone weaker leading to the osteopenia and even osteoporosis is when the density of the bone will be decreased when the bone is not proper formation of the calcium, then a high risk of the fracture, especially in the hip, wrist, and spine. I am showing this diagram and in diagram vertebra fracture, bone density occur in the most of the this reason in the skeleton system in the occur in the next we are discuss about of the cardiovascular and central nervous system. First of all, the cardiovascular system decline the estrogen level to the decrease the production of the against the cardiovascular disease, increase the LDL and decrease the HDL, and the cholesterol result in the high risk of the hypertension and atherosclerosis. They may be occur due to the bad cholesterol formation due to the high risk of the hypertension occur then the brain function many changes occur many women experience is a Physiological shifting include the mood swing, anxiety, depression, memory loss, direct related to the fluctuation of the hormone level in the brain. Mostly we are seeing the persons are, I am not remembering proper, some thing place in the room, and after they seeing forget. These conditions are mostly happen in the menopause patient because of the they loss of the memory, and some anxiety also feel, and they feel a loneliness because they in mind many hormonal changes due to the depression occur, memory loss directly related to the because of the immediately effectuate the hormones level in the brain. That's why the many these problems occur in the menopause conditions. And then thermoregulations, hypothalamus experience through the changes occur, severe sleep disturbance, night sweating, frequently hot flashes, and then disturb the sleep pattern also because of the when the hypothalamus is a regulate the body system, and the then we are when immediately temperature occur, that time night sweating occur, and patient is a discomfort to sleeping, so these changes are many occur. Next we are changes in the journal appearance. When we are seeing the menopause person, then see skin and weight. Skin sometime many changes because of the loss of the elasticity, become thinner, much dry due to the systematic loss of the elastin and coagulation. Weight increase the common due to the irregular food in habits, like slowing metabolism, fat distribution shifting, the more occur in the hip area, wrist, buttocks, and hair and voice also changes. Here, what were the changes in the hair? Dry and loss of the decrease the estrogen level, and thin hair occur in the because of the thin hair. Why are occur? Due to the hormonal changes. Increase hair, head hair is a loss, but facial hair may be appear due to the general hormonal imbalance. Okay, voice. The voice may be slightly deeper due to the thickness of the vocal cord occur over the time. Then we will discuss about the changes the vasomotor system. Vasomotor is a system. First of all, we are discuss about of the changes like symptom. We are discuss like hot flashes. Hot flashes, woman is a get a sudden feeling warm, sudden feeling cold around the neck and upper body. They can be anytime verify in the 1 hour to the 15 minutes because of the profuse sweating. Why is sweating occur? Because of the hypothalamus system changes. Directly, we are our body's brain system is a control the our thermoregulation system. That is not a control because of the immediately fluctuation of the hormonal level. Night sweating, closely related to the hot sweating, is a mostly occur in the night time, while it is a enough the woman wake up from the sound sleeping making difficult go to back sleep. Night sweating may be disturb the female sleep pattern also, and secondary effect, they sudden wake up of the sleep induced through the night sweating can be cause of the palpitation on the sometime is a trigger and panic attack leading to the chronic fatigue. And due to the when person is immediately get up from the bed, that is sometime occur in the panic attack also occur. So many changes in the occur. And next is a physiological changes in and social changes, psychological changes and social changes. There are many changes in the headache, irritability, severe fatigue, depression, insomnia, while often directly in the hormone drop. Maybe these issue is a chronic sleep loss due to the night sweating, and interest in the sexual maybe from the emotional upset in the secondary physical pain in the due to the dry vagina. Next is a social adaptation because of the woman feeling is a hair self of the relationship among the symptom severity. Can be defined her the woman greatly is the subjective experience, no perceiving the bodical changes visible, maybe stem from the woman changes self perception and adjusting the actual living experience. First of all, they not showing their body structure many changes, they not adjust in the society, they feeling shy because of the changes occur in the body. So conclusion, menopause involving the complex of the system in the physiological changes in the profound various organ due to the natural decline of the hormone and particular estrogen changes significant impact in the woman daily life, emotional well-being, long term in the. However, the risk of the can be managed by the lifestyle changes on the hormone replacement therapies. Now we are discuss about what are the things are we are showing for the treat the menopause. Some medications, some doctor also allow the for some medication for the treatment like hormonal replace therapy will be given to the person. And most of all the these changes occur in the age of the 40 to 55 years. So person is feeling very bad, not just in the society, so many changes occur in the this time. So endocrine organ system, endocrine changes, what are the endocrine changes occur? First we are discuss about of the endocrine changes. Endocrine changes occur like estrogen level will be decrease, prostrogen level will be decrease, inhibitine hormonal level will be decrease, FSH hormone will be increase, and LH hormone also increase. So hormonal changes and estrogen decrease, prostrogen decrease, decrease the inhibited B decrease, and decrease the FSH. So increase due to the reduction of the negative feedback, so become the small less activity, physical activities decline, estrogen progesterone production, uterus becomes smaller, endometrium become thin, inactive, become shorter and narrow, vaginal mucus become thin and less elastic due to the lubricant, maybe breast changes, gradually tissue decrease, fat connective tissue become the rapidly prominent, and breast tissue become less firm, skin supporting tissue may be loss, bone changes, estrogen deficiency increase the reabsorption, and density decrease, increase the risk of osteoporosis, fracture risk, advanced aging, cardiovascular changes, lipid metabolism changes, cholesterol may be increase, and loss of the estrogen, increase the cardiovascular risk, and menopause mm, and function may be changes, skin hair changes, claws and hair become thin, hair distribution of changes, urinary tract system changes, and many changes occur. We are discuss overall this all changes we will be treat with the help of some medications and some with the help of the hormone replacement therapy. In the now market very treatments are available, like we are discussed about of the hot like hot flashes, some use for the night time, medications for the sleep, and lubricant the vaginal area with the help of the lubricants, and that is helpful in the without painful sexuation, and the mood changes occur, and many changes occur. So this life is a totally change after the menopause, but with the help of the medications and some treatments we are treat the these symptoms, or peaceful life will be alive. So thank you very much for the this a topic for given to the me. I am very thankful to the whole persons, and good afternoon, everyone.
ਹੋਰ ਕਿਹੜੇ ਕਿਹੜੇ ਬੋਲੇ ਸੀ ਜੀ?
Thank you so much, ma'am, for enriching knowledgeful session. I hope so that you all have learned lots of things about the menopause health, and so that you were not aware about before this session. And I hope that this session will enhance your knowledge. It will feel something unique, something different, something new into your knowledge session. So within some time, we are going to have our next session. So moving further, now it's time for our last session, which was the most awaited one session about our speaker, Miss Dr. Virginia Verghese from Oman. She is a distinguished nursing academic with extensive experience in teaching, clinical coordination, research, program, leadership, quality assurance. Her academic journey, culminating in a PhD in nursing, reflects her strong commitment of lifelong learning and professional excellence. She has over 18 years of academic teaching and leadership experience in India as well as Oman. Active research and publisher, author with multiple journal publications and ongoing funding research projects, including collaborations with Royal Hospitals of Oman. Invited as keynote speaker and resource person at international webinars, this list is never ending, and I feel that I'll be tired of her achievements, that what she has gained in her life. So now it's better to hand over the session to ma'am so that she can teach us with the session third of our today's webinar. So ma'am, I welcome you to the session. Please take the place.
Hello, am I audible?
Yes, ma'am, you're audible very clearly.
Thank you. Thank you so much. And thank you so much for your warm introduction. Happy to have.
My pleasure.
Thank you. And happy to have here in an online platform to deal with the students as well as the faculty. On the topic, assessment and management of menopause, I would like to extend also my thanks to Dr. Jasmine, who have warmly welcomed me and given the topic of my suggestions. And thank you so much, and entire college students and the faculty. And I hope my presentation will be useful and it will be enhancing your knowledge as well. So let's start the topic. You have seen so far menopause, the managements, the concepts, the types, and what happens in endocrine as well. So moving on to here, it's assessment and management. Let's say menopause is not an easy thing. When it comes to women, maybe sometimes 40 years, all the women, especially everybody, on a period of average, every month we will have this problem, right? But menopause is not that simple or easy task to deal with. Menopause is a little bit difficult. You have to ensure that you deal with the situations and carefully. So there are lifestyle changes which I will come across in the coming slides. Please, can we move on to the next? Yeah. The scope of the section here, what I would like to go with is clinical assessment, the symptom prioritization, risk stratification, individualized management, the menopausal hormonal therapy. Later on, I will mention as MHT, What will be the selection? What will be the route? How will the progesterone help you? What is the risk communication to be done for the patient? So there are also non-hormonal therapies, and recent advancements are also there in terms of menopause. Also, one of the recent advancements as a part of Indian Menopausal Society is genitourinary syndrome of menopause, which we call it as GSM. And also sexual health, which is neglected or ignored because of the embarrassment and follow-up. So the clinical pathway which I am going to discuss is assess, stratify, treatment, and follow-up. So what is a contemporary? Usually, regularly, what is the practice what we follow? First is symptom domains. As many of the previous speakers have mentioned about vasomotor symptoms. There are so many vasomotor symptoms which you may know by now. Hot flush, sweat, palpitation, so the night sweats. Sometimes I will tell you one story. There is a person who is my colleague in Oman actually. When we were discussing about menopause, she was mentioning to me that at one point she even felt that she want to go and stand in the middle of the road, and she want to herself being hit by a truck or whatever it is and just die. So those kind of highly elated mood swings and changes will happen in the body for a female. So mood and psychological symptoms are there for the females. Genitourinary symptoms. Sexual well-being is normally assessed. Musculoskeletal and cognitive concerns, because normally whoever has a PCOD, their menopausal symptoms will be much more aggressive. So coming on to the midlife health domains. What is midlife health domain? When I say midlife health domain, it means from the age of 40 to the age of 65, you will have, as a woman, your hormonal levels are changing. Your estrogen is changing, your progesterone is changing. So you are at risk to have lots of problems in the body, which is cardiometabolic risk, bone health, fracture risk, cancer history, which is very highly elevated in Indian scenario, especially breast cancer, mental health and psychosocial context, patient goals, and treatment preferences. So these are the domains which you will see in my coming slides also. So usually there is a keynote mentioned below, which is treat the woman, not simply the hot flush. Can we go to the next slide? Yeah. Coming on to the symptom assessment. And usually you know the symptoms. You are very well aware about whatever symptoms happen in the body. So main thing is take a note, take a diary, document the frequency, severity of your mood swings, the functional impact it happens in your body, like maybe you are not able to sleep, like you feel that you want to kill yourself, your anxiety level increases. Everything, if you note it down, it will be easy when you go to the hospital. So also, any patient comes to you, you have to ask about how long they are sleeping. Usually after 40s, the problem is our magnesium level comes down, our calcium level also comes down. This will affect our serotonin level, and this will cause our sleep to have disturbed. So once our sleep is disturbed, you know that our work, relationship, the sexual function, the family function, everything will be distorted. So you should have some validated symptom scales. There are menopausing rating scale, menopausal quality of life scales are also there, which is standardized scale, which is used. Many researchers and recent researchers are also there on part of that. Or even if that is not there, you cannot give to the patient hot flush diary. How frequently you have this problem can be mentioned. Okay, so when you ask this patient, identify the priority. Priority means what? What affects your life most? What will affect your life most? Whether it is a sleep, whether it is hormone, whether it is your severity, whether it is hot flush, what among this is highest problem? Whether it is, you can see a picture over here, where it is chills, night sweats, whatever it is, or sometimes weight gain even. So reassess the same outcomes even after the treatment. So that is important when it comes to symptom assessment. Let's say you started a medication, you started a treatment, or you started a hormonal therapy. However, after when the patient comes to you for another 1 week, you have to still assess what are the symptoms it happens to the patient. Okay. So can we go to the next slide? Yeah. So clinical history. There are some essential clinical history we have to obtain. One is normally when it comes to menopause, you have seen in the previous slides that the menstruation will slowly come to an end. Scanty menstruation will be there. So you have to ask the patient, what is your current bleeding pattern? And when was your last menstrual period? Let's say it was in January. They will say it was in January. Now it is August. It's like 8 months. So that is what you have to ask. Check if the patient had a hysterectomy or an oophorectomy, or she is on a current contraceptions. That is very important. Why? Because hysterectomy induced menopause also is there. Check also if the patient is hypertensive, diabetes, having dyslipidemia, having migraine. Migraine is a very big concern. And VTE, venous thromboembolism, and cerebrovascular disease and liver diseases. Also check when the patient is coming, assess the patient for if she has an endometrial, ovarian, or a breast cancer, which is very important. I will come to that in the coming slides. So in case if a patient is taking any medication, because 40, 50 years, definitely there will be one or the other problem if she is not maintaining the health. So ask what are the medications she is taking, and does she have herself took any medications like estrogen, estrogenic foods, or estradiol likewise. Coming on to the family context, we have to ask if the family has a history of breast cancer, venous thrombosis, or if there is any premature cardiovascular disease for them. Osteoporosis is very important. Why? Because when the estrogen level decreases, the calcium deposition decreases. After the age of, the study says that after the age of 35, the calcium deposition into your body will be less, which will lead to hip fracture. So there are some people who have a habit of alcohol, smoking. They are not doing any activity, sedentary activities, and they don't maintain the diet well. See, normally I would suggest everybody one thing, that you have to ensure that whatever is your weight, let's say 1 kilo or let's say 50 kilo. If you have 50 kilo, you have to ensure 50 grams of protein is taken into your body. If you don't take 60 grams of protein, it will affect the entire hormonal functions. Then psychological stress. Are they working? How is the relationship? In current scenario, there are so many stress factors which causes lots of issues. And as a female, we already are working. We already are taking care of the home. We are already taking care of the children. We have many financial matters. This all will aggravate and make a various variety of changes, variations in our hormones. So this is about the clinical history. Can we move on to the next slide, please? Okay. So what are the investigations? As a normal investigation, it was not suggested by the Indian Menopausal Society to start directly with anti-Mullerian hormone, which is AMH, estradiol, inhibin A and B, or ovarian reserve test. Why? Because this is symptomatic. For any patient who is symptomatic, you are not it's not mandatory to do this test. But if a patient is early menopausal or having POI, which is nothing but primary ovarian insufficiency, in that case you have to go for the test. FSH is nothing but follicle stimulating hormone. It is sometimes in all the patients we don't do, especially 40 to 45, still the ovarian functions will be there, because now the reproductive age is a little bit different. Previously it was 35. Now the reproductive age is up to 40, because 40 is also the woman get married, or even they get children. So that's why the reproductive age is slightly changed, and that's why the follicle stimulating hormone test is not done for a woman who is in 40 to 45 and symptomatic. Investigate whether the patient is having thyroid, which is very important, whether she is pregnant by pregnancy test, hyperprolactinemia. When prolactin is high, it also affects your estrogen progesterone levels. Anemia is very important, because all these things aggravates to abnormal bleeding. So apart from these normal investigation, you also have to do your cardiometabolic test, which I have heard from a previous speaker about the cardiometabolic syndrome symptoms and likewise. So those things have to be checked. The bone, which is very, 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 very important, and cancer investigation. Nowadays, cancer investigation can be done very easily by even your saliva. So it's very easy a test, and I'm not sure in India where you will get, but in most of the sophisticated hospitals you might get this medication. So what I have understand through the clinical researches are clinical assessment is first and testing is second. So whatever I have mentioned in the previous slide about assessment, that you have to follow. Hope this is clear. Can we go to the next slide, please? Okay. So coming on to the cardiometabolic assessment, normally any patient who are at risk for cardiac, you have to assess all those risks, whether they have high BP, whether their cholesterol level is normal, whether their lipid profile is okay, are they overweight, when they move, their treadmill test, everything has to be assessed. Apart from that, BMI is very important. You have to have a normal body weight. Weight circumference matters. Especially when you have underwent a class or anything, you may have seen that the waist circumference, when it increases, it causes a problem to the body. Why? Because adipose tissues are not helping you to store your cholesterol, right? So, plus assess the smoking, physical activity, what is the dietary pattern? Identify if the patient is a diabetic, having dyslipidemia, or a family history of premature cardiovascular disease. In case all those things are still there, you can go to the next is what is recognize adverse midlife changes. What is midlife changes? Let's say when you are crossing the age of 40, you can understand that the body is weak, you are tired, you are not like the normal self. So you will be finding it so difficult to make sure that you are not able to get up on time, you are not able to do your work on time. You will have bloating, you will have gas issues likewise. So, but this doesn't contribute to the metabolic risk alone. This is a factor. So, you will feel tired, you will feel exhausted, you will feel not able to do anything. You will feel a little bit detached. So, what you have to do is, before going on to menopausal hormonal therapy, make sure the cardiovascular risk is assessed and they are taken care of. Okay. So, it is not a prevention. It's not treatment, it is prevention first. Because if you prevent cardiovascular, if a person is an alcoholic, if a person is not doing an activity, what we will do? We will ask him to walk for 10 minutes today, increase for another 5 minutes, then take a proper diet, which includes everything, a complete meal, which is protein, fat, carbohydrate, which is very less. Then in case if a patient is not able to take this, they have to take it, go to the hospital, take it by supplements also are there. But supplements, I always say, and I always suggest that it has to be consulted by the doctor. Okay. So can we go to the next slide? So individualized management. Okay. So lifestyle foundation, but not constitute for the need of treatment. So usually anybody, you have seen my first slide, lifestyle management. Lifestyle modification is very, very, very important when it comes to menopausal management. So what is the core measures? What I'm going to suggest is to everybody who is going to reach 40, 45s, likewise, the core measure what we have to do is regular aerobic exercise and resistant exercise. Resistance means we are pushing ourselves harder. Our muscles, most of you might know, our muscles degrade. Like every year, if you are not using your muscle properly, it will degrade slowly. Once your muscles degrade, you will become thin, 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 and thin. Your muscles are no longer going to function. So you have to ensure that your muscles are moving and it is helping you to enhance the buildup of your body. So regular aerobic and resistant exercise is very, very, very important. Healthy diet. I have emphasized many times, several times here, healthy diet, which is a healthy plate. When I say healthy plate, as I mentioned previously, the protein, according to your weight, 1 kilo is 1 gram, which means, let's say if you are 60 kilos, you have to take 60 grams of protein in a day. Protein can be anything, egg, Whatever it is you are feeling comfortable, you can take it that way. Sometimes even some women, they feel that the lentils, when they take, they will feel bloating. What they can do, they can use even the protein powders. That is also safe to use. So weight management, usually there is now a syndrome or a problem which is cortisol. High cortisol level is there. So when your cortisol level increases, your weight also increases. Your body is inflamed. That's the problem. So cortisol level has to be low, which helps for the weight management. Okay. Smoking, alcohol cessations is a must. Sleep hygiene. What is sleep hygiene or sleep pattern? If you take a small nap, a 30 minutes nap in afternoon period, that is also fine. It is sufficient. It is sufficient. It means it helps your body to relax. And 7 to 8 hours of sleep is always mandatory. Usually, previously it was mentioned, and usually in the football and all, if I say football, I think students will more interested. Football, Ronaldo will sleep for how many hours? 4 hours. He will cut his sleep, take 2 hours, 4 hours likewise, and he's sleeping for a minimum of 8 hours. Why 8 hours matters? Our body has to reset, our serotonin level has to reset, our cortisol level have to come down, we have to be fine, and our brain has to be fine. So, sleep hygiene and stress management. We women, I always advise we have to manage our stress. If you don't manage our stress, nobody else. When you want to ventilate it to either your husband, to your kids, to your family, to your friend who is very nearby, or even now lots of consultations are there. You can go anywhere, which is stress management is really, really important. In case if you cannot do any of these things, go for a walk, go for a trip. There are lots of girls trip over here. Then many things are there which you can manage your stress. Stress management is very important, because even if you do everything but you have stress, your body is not going to cope with menopausal management. You will be ending up with a disaster thing, and you will be hospitalized every now and then. You will be having to go to hospital. So what is your clinical role? As a clinician or as a person who is in the clinical, what is your role? So cardiovascular support. If you have dyslipidemia, make sure you may take the medication for cholesterol control. Bone health, if it is not good, you have to ensure the calcium with vitamin D is adequately taken in the body. This will improve overall coping of your body. So once it is improved, then you can start for the significant treatment of your symptoms. Symptoms what? The menopausal symptoms, like vasomotor symptoms. So it is not suggested that the menopausal treatment for is very particularly this. No, it's not hard and fast rule. For a woman who has menopause, let's say I am having menopause, my symptoms, my treatment will be different. If another person is having menopause, their symptoms, their treatment is totally different. That's why it is individualized. And it has to be sustainable. Sustainable means it has to stay long, and you have to follow it for a longer period of time. Can we go to the next slide, please? Hello, can we go to the next slide? Yeah, thank you. So coming on to the vasomotor symptoms, practical treatment pathway. You have confirmed your symptoms. What are the vasomotor symptoms? How far you have the burden? You have noted it down. You have documented it. You know the frequency. You know the impact, what it is happening in your body. How long you're not sleeping. How is your quality of life, right? So whatever menopausal hormonal treatment are there, you have to select, make sure. Sometimes everybody will not suitable for estrogen alone. Maybe they have to take progesterone also for you. So discuss with your doctor the benefits, what are the risk factors of that. Some candidates who will take menopausal hormonal treatment, it will be like they will have moderate to mild symptom variations will be there. In case if it is not working, then you have to go for non-hormonal options. So always review the response of the patient. 1 week, 2 week, review the response. Then you have to adjust the dose. So then only you have to understand, go to a conclusion that the treatment is failed. No, it takes time. Your body is completely changing. Imagine your body is getting food every day and you're stopping it. It's saying like what is happening here also. The body, you are going on a hunger strike and you are not going to eat anything. Likewise, your hormones were supplied in the body. One point, your hormones are out. Okay. So your body is resisting to that. That is what you have to give time for your body to adapt to whatever treatments and whatever methodologies you are going to use. Can we go to the next slide, please? Okay. So in case if you're going for a menopausal hormonal treatment, there is two things which you have to go. Some women, they may have underwent a hysterectomy. Some women, their uterus is intact, which means uterus is not removed. So you have to understand that if the uterus is not removed, the estrogen level is still there in the body. So systemic estrogen will be there. In a little bit, you have to add on some progesterone, you will be fine. So choice always depends on the bleeding status. If you remember the first slide, I have mentioned that the bleeding status has to be assessed. So once you start the treatment, estrogen and progesterone, check again the bleeding status. Some people, they may bleed more, which you may have to stop the medication, you have to adjust the dose. If it is a patient who underwent a total hysterectomy, the only option what you have, there is no systemic estrogen for them. The only option what you have is estrogen only therapy. Let's see, in some conditions, some rare condition like endometriosis or cancer, there are some other options which will come into the further slides. So you can use other route, other dose also. So start with the lowest dose, slowly increase the dose, see the bleeding pattern, and if it is fine, then go ahead with that medications for a couple of time. So can we go to the next one, please? So when I say other medications, we have oral estrogen and transdermal estrogen. What is oral estrogen? It's very easy. It's oral medication, right? It's very convenient. It's familiar to everybody. When you take any medicine by mouth, you know that it bypasses the hepatic metabolism. So as it bypasses the hepatic metabolism, it will enhance the protein intake, triglyceride intake, and you will be fine. And it will absorb in the body very fast. But if it is a transdermal patch, you know what is transdermal patch, right? It is a patch which we apply, or a gel or a spray. Many things are there in transdermal estrogen. So what happens here is, it's applied on your skin or it's applied as a gel. So it is not going into your oral route. So there is no hepatic metabolism. So one main concern with this is it will have a problem with your venous thrombotic embolism, because estrogen will bind with your thrombotic factors, coagulation factors. So in this case, if a patient is a cardiovascular patient, avoid transdermal patches as much as possible. So in case if a patient is obese or having obesity, you have to ensure that it is taken care also. You can go to the next slide. It is the same, but a pictorial representation. You can see here why the first pass metabolism is there in oral estrogen, which is pill, and how it bypasses in the transdermal patches. It bypasses directly because it penetrates into the skin. So the one key difference is only thing, it bypasses the liver. So if it is going through the liver, it undergoes coagulation also. That's why absorption is faster. We'll go to the next slide, please. Okay. So in estrogen, you have done, you know about estrogen now. Let's see what is progesterone going to do. There are wide varieties of progesterone. Progesterones are so many. So options are micronized progesterone, dihydrogesterone, synthetic progesterone, levonorgestrel is there. Many options are there. But how these options will be used? These options will be used if your endometrial layer and thickness of your endometrial is good. So this helps your endometrial protection. Also, whenever you give a progesterone, you will also ask the patient if you have a bleeding, are you okay? Sometimes some people will sleep, sometimes some people will feel hungry, they will eat more. Sometimes some people will have to take even a contraceptive measures because the possibility of pregnancy is still there. So progesterone duration doses always combined with this estrogen as well. Okay, so it is like a combination, like your both hands works together. Likewise, it's like a combination of progesterone and estrogen. We'll go to the next slide. So MTH and cardiovascular risk. So I would like to suggest some very simple messages for those patients who has cardiovascular problem. So do not start a menopausal hormonal treatment for any people who has cardiovascular. Why? Because these estrogen level will affect the coagulation. The cardiovascular factors are very difficult to manage once your coagulation profiles are different, right? So check the age, check the time, check the cardiovascular risk like weight, BP, diabetes, smoking, then BMI, family history of cardiovascular disease. Likewise, the route which is giving, whether it is an oral or a transdermal, what are the doses you are going to give, whether it is 25, 50, whatever it is, and comorbidities. Comorbidities means along with cardiovascular, whether the patient is already having a diabetes or whether the patient is having a liver issue or a kidney issue, you have to assess. So if you start with oral medication, you cannot switch. Oh, oral is not working. No, I want to switch to transdermal. No, it will not work likewise. So it is not interchangeable because risk factors are very high. So it is not interchangeable. So whenever you are going to start a treatment to the patient, ensure that you communicate the risk to the patient. Risk factors, because there are risk factors you have to communicate to the patient. Yes, you can go to the next slide. Okay. So coming on to the breast cancer, I was telling you that regarding cancer, I will come to that in the upcoming slides, right? Coming on to the breast cancer, after 40s, the risk of breast cancer is very high, right? Many patients, you may have seen when you go to the hospital, you may have seen many patients come. I'm sorry, many patients come with some cancer issues, family history of cancer, breast cancer, especially females, breast cancers are very high. So in that case, when it comes to a cancer, giving estrogen is again a risk. Why it is a risk? Because estrogen increases the cancer cells. That's a reason researchers, it's not a reason also as actually, but the reason Harvard University researchers have told about estrogen and the problem of estrogen in cancer. Okay. If in case if a patient is taking progesterone, you have to also ensure that what type of progesterone is taken. What type of progesterone is taken by the patient? 1 second, please. What type of progesterone the patient is taking and whether this progesterone is going to impact the cancer of the patient. One second, please. Okay, sorry, I was having a hiccups. That's why. Sorry for the interruption. So, the risk factors you have to be very careful with. So, in case you are going to take a treatment for, especially with a cancer patient, the decision should not be the sole responsibility of the doctor or the nurse. It has to be a sole responsibility of the patient also. Because later, the patient should not blame us that the treatment happens or my cancer worsened because of this. Especially for a female, once a breast cancer is there is a problem. After breast cancer, it goes with the bone, it goes with the uterus, it goes with the ovary, likewise it aggravates. So that's why always the breast cancer has to be managed. Can we go to the next? So coming on to the non-hormonal managements. Coming on to the non-hormone managements, the behavior psychological managements are there, which is menopausal specific CBT. What is CBT? Anybody knows what is CBT? It is nothing but cognitive behavioral therapy. My PhD was on mindful based cognitive behavioral therapy. It's very good. It's really good. It was very effective among the premenstrual people, which was my study actually. I'll tell you one small example of that. What is that small example is, when it comes to mindfulness, let's say you are all disturbed, you are tired from listening to this speeches from the morning itself, right? Let me ask you one simple question. What comes to your mind when I tell about your favorite food? When I say your favorite food, many things comes to your mind. Maybe chapati, maybe I don't know in Rajasthan what all the different foods are there. Those things come to your mind. When that thing come to your mind, did anything come? Anything else came? No, it will not come. When it comes, when you're listening to your favorite music, you will only listen to that. You won't listen to anything else. Why? Why is because your mind and your brain is completely into that. So this is known as cognitive behavioral therapy. When you put your mind into that, you will completely think about that only. This is called as mindful based cognitive behavioral therapy. So when it comes to non-hormonal management, lots of recent studies have told that cognitive behavioral therapy is highly effective in reducing the mood swings, in reducing the psychological symptoms of the patient, in reducing the overall well-being of the patient as well. Sleep interventions. You may have heard about guided imagery. Guided imagery is nothing but while sleeping, you can put a headphone or whatever into your mind, and now lots of sleep musics are there. It will walk through a beautiful garden. It will walk through, let's say, a beautiful place you want to be. Let's say the house you're going to build with. Those are your interventions, which is about sleep. This is where also effective. Lots of studies have told about the sleep intervention effectiveness. Lifestyle optimization. When I say lifestyle optimization, it's very important in terms of sleep, quality of life, stress management. Next, what I'm going to discuss is targeted management of anxiety and depression. So many women, they are not able to open and talk. So in that case, what happens? They go to a depressive stage. This has to be identified by the family, by the husband, by the children. You have to see whether your mother is fine, whether you are okay, whether they're eating well, whether they are sleeping well, right? So these managements have to be done at home. In case if you cannot manage at home, there are psychological centers, there are counseling centers which you can go and get the treatment as well. Coming on to the pharmacological management, there are so many medications over here which helps to reduce. One is neurokin 3 receptor antagonist. Most of you may have completed pharmacology, or those who are studying pharmacology, it will not be a new to you. It's a common medication which is neurokin 3 receptors. This reduces the vasomotor symptoms. Vasomotor symptoms which you have seen previously, hot flashes likewise. Then selected serotonin reuptake inhibitors, which is also very good. What it is doing into your body is it will reduce your depression. For women whose depression cannot be managed, it will reduce their depression. Then gabapentoins. Gabapentoins, maybe you have seen, it is an anticonvulsant. Also, it is a neuropathic. You may have seen that this medication is usually given for neuropathic pain, especially hot flush, palpitation, likewise. So non-hormonal care is not a secondary care. It is very essential for many patients because all the patients, as I said, it is an individualized care. All the patients will not respond to menopausal hormonal therapy. So you have to go for non-hormonal managements also. Can we go to the next slide? So menopause specific CBT, where does this fit? CBT is nothing but cognitive behavioral therapy. So lots of evidences, lots of researches are there that it will reduce the vasomotor symptoms. In case if a patient is using hormonal therapy, you can use along with that. In case if the patient is not using or not able to use hormonal therapy, you can still use CBT. CBT is highly effective. It's done it's usually an 8 weeks time. It can be tapered down to 6 weeks, 4 weeks as well for any patient. Also, there are online sessions for CBT as well, which is also very effective in understanding what is CBT and how to do CBT. So many patients, behavior, cognitive process have completely changed, and the symptoms have reduced. Especially it is used for insomnia, anxiety, coping difficulties, etc. I'll go to the next slide, please. Can we go to the next slide? So, I didn't tell about neurokine receptor 3. So, neurokine receptor 3, the medication what we usually see or have seen is festulintant. Festulintant is nothing but this help to reduce for those patients who have a moderate to severe vasomotor symptoms. Not a patient who has mild symptoms. It is not at all suggested. So, what it is doing? Usually, you know that your hypothalamus is controlling your body. So the reproductive hormones are controlled and your body temperature is controlled. This will help to reduce the hot flush. So once your hot flush is reduced, the patient will feel a little bit calmer. Imagine you're always feeling hot. It's not good, right? Imagine you're always feeling cold. It's not also good, right? So you cannot have both extremes of temperature. It should be normal. It should be like a minimal temperature for you. So this will reduce your hot flush, which helps the patient to completely be fine. So in case if the patient don't want hormonal therapies, then this medication can be continued as well. But check if there is any contraindications. And each country to country, the protocol is different. So this is a common medication which is seen all over the world. That's why I have mentioned the fesulintin medication. So major advanced medications are there, which also can be used. It's just evidence-based choices only. Lots of researches are happening in pharmacological field on that. Can we go to the next, please? Okay. So, coming on to the main topic or the main emphasis on menopause is genitourinary syndrome of menopause. You have to ask. There is no need to embarrass. I have mentioned here embarrassment. It is not to be omitted. It cannot be omitted as well. It is not to be embarrassed also. We have to ask any patient coming. Any question answer can be answered later also. No issues on that. Symptoms like vaginal dryness, burning, irritation, dyspareunia, reduced lubrication, urinary urgency or dysuria, or recurrent symptoms. Any of these symptoms have to be checked. The main thing, what the problem with the woman is, they will feel embarrassed. When they feel embarrassed, they will not open their symptoms. If they don't open up their symptoms, they will not get the treatment properly. So we as a woman have to understand that our body will undergo a normal aging process. Symptoms are there. Clinicians will focus on mostly hot flushes. But as for us, as a nurse, anybody coming to us, we have to ask this. We should not be feeling bad. Why should I ask? Should I ask? Those kind of questions should not be there in the mind. If you don't ask about the GSM, which is genitourinary syndrome of menopause, you will not diagnose it. That's the main problem. Can we go to the next slide? Yes. If there is a mild symptoms, very mild symptoms, mild dryness, mild irritation, then there are so many available vaginal moisturizers are there. Lubricants are there which can be used. Also, in case there is a sexual pain, it has to be assessed. And what is the contributing factors on that has to be assessed. In case it's not a mild, it's moderate to severe, then the low dose of estrogen has to be started. And many other methods are also there, which is available in the local market or available in the Indian community as well. So according to the symptom of the patient, you have to assess or give the medication for the patient and reduce the pathological conditions. So in case if you don't take GSM properly, genitourinary syndrome of menopause, it is going to be chronic, it is going to be progressive, and you may have to take treatment for a longer period of time. We'll go to the next slide, please. Sexual health, the very much ignored thing. When it comes to menopause, the sexual health is also to be taken care of. Check whether there is a desire, arousal, pain, satisfaction for the patient. Usually when it comes to the hormonal levels, declination, the levels of sexual health is also less. So look for whatever I have mentioned previously in the GSM. In case if they are taking any medication, could it be the problem of for the male or the female? Is there a depression for the patient? How is the relationship? Is the patient feeling always isolated? So before labeling the patient that this patient is not sexually healthy, you have to understand what are the symptoms that they have. So before labeling anybody, what is the problem listed down, then you have to start. So in case if the patient is not having any desire, testosterone is good. Testosterone is very good in some select. The results have shown that the post menopausal women, when the testosterone was used, they had a changes in the sexual health. Can we go to the next? Okay. Some special situations, like let's say there is an early menopause, which you have seen in the previous keynote speaker was mentioning. Early menopause, check if the patient have exposed to estrogenism, because some people, some women, the estrogen level will decline very fast. By age of 25, 30, they will have menopause, and they completely the menstruation will stop. Also assess their bone cardiovascular disease, whether there is any taking any hormonal contraceptives, whether how is their fertility, whether they have primary infertility or the secondary infertility, how is their psychological impact. In case if it is a cancer, as I have mentioned previously, multidisciplinary team should be here. Multidisciplinary team, when I say, it is everybody, doctors, physicians, pharmacists, cancer diagnosis, everything will be there. Also, whether they have taken any non-steroid hormonal symptoms, do they go for a review, are they managing their genitourinary symptoms, those things also you have to concentrate on. We'll go to the next, please. So what is a follow-up? When it comes to follow-up, it has to be efficacy, has to be maintained, safety, patient experience, everything matters here. So once you start estrogen, or once you start HRT, once you start CBT, once you start estrogen, once you start progesterone, that doesn't matter. Whatever you started, reassess your symptoms. It's very, very, very important. Reassessing symptoms is very important. Then you go for the treatment priority, because maybe today you have given estrogen, it didn't work for the woman. Maybe you have asked the woman to go for a CBT, but it didn't help, or the person was not useful with CBT. We don't know how they are doing. So also check whatever treatment you have given, HRT, estrogen, progesterone, anything you have given, check whether their adherence, how far they are taking the medication, the dose, the route, and how far they are tolerating, because some medications are not tolerated by everybody. Review the adverse effects, and any new contraindications are noted by the patients and it is reported to you. In case any unscheduled bleeding according to the regime time, endometrial cancer risk also has to be assessed, because some patients, once they start treatment, they will have some bleeding, like on and off, we say. So revisit whether the benefit is balanced and patient preference have changed, patient's mood is improved, then only you can go further. Okay. Stopping rule is not at all, it is individual assessment, because let's say one patient is taking 6 months treatment and you want to stop. No. Check whether you can stop it now, or you have to reduce the dosage. Some patients, even they will take lifestyle modification, they will go to gym, they will go to do exercise, they will manage their stress, everything will be managed. So their medications can be stopped at once, or whatever you can do. No issues in that. But the problem here is it's difficult. So unusual bleeding. When it comes to unusual bleeding, I have mentioned previously unusual bleeding, right? Bleeding can occur when you start HRT or when you change the dose of HRT, especially estrogen, progesterone, and progesterone pills. So what time you take, how far is the bleeding, how is the pattern, it is on and off, you have to check. Are they following the medication? Do they have an endometrial cancer? Do they have a cervical cancer? Has to be determined before going on to a conclusion. So heavy bleeding or consistent bleeding, those things have to be assessed. So also suspect cancer, especially cervical cancer. Do not ignore bleeding. So anytime patient is coming to you saying that I have bleeding, please don't ignore. Why? Because it may be a new symptoms which has been developed. Either it may be an endometriosis, a cervical cancer, or an endocrine cancer, whatever it is, you cannot ignore the symptoms. Can we go to the next one? Okay. So this is an algorithm which everybody has to follow when it comes to menopausal management. First is assessment. You have to know the symptom, how is impact, what is the history of the patient. Stratify. When I say stratify, is there a cardiovascular problem? Is there a bone issue? Is there a cancer issue? Is there a mental health or sexual issue? You have to know. Prioritize it. What do you mean by prioritization? Let's say if it is a sexual issue, you have to prioritize that. If it is a genitourinary symptoms, you have to prioritize that. If it is a cardiovascular, you have to prioritize it. If it is a cancer, likewise. So treat either MHT or non-hormonal therapy or GSM therapy. Anything is fine. No worries on that. But review is very, very, very important, which I have to. Efficacy, safety, satisfaction. Is there any new risk? 4 things you have to keep it in your mind when patient is coming for a review. Efficacy, safety, satisfaction, and new risk. So in general, we will tell assess, stratify, individualize, treat, review. Okay, please go to the next slide. Yeah, there is an evidence updated according to the new standards of Indian Menopausal Society, which is 2026. They have mentioned that for 30 domains, they have mentioned lots of changes. 30 domains are nothing but starting from heart, bone, sexual health, woman health. Likewise, they have prioritized each categories, and they have mentioned whatever I have mentioned previously. All those things are from the recommendations of IMS. And NICE is nothing but National Institute of Health and Care Excellence, which is in UK, is now concentrating on CBT, which is cognitive behavioral therapy. GSM is nothing but genital symptom management. HRT, and there was a recent update in April 2026 about patients on how to use this and how effective is the utilization. Indian Menopausal Society also provides a contemporary region guidelines, especially for Indian and an Asian clinical practice, because Indian practice and Asian practice is a little bit slightly different. So care here is not care for all. No, it's individualized care. 10 women are coming, their treatment is 10. The 10 treatment goals are there, but there's a shared decision making, which means as a doctor, I'm not going to tell this is your treatment, go for it. No, because it won't work likewise. Why it won't work? Why? Because the patient, when they go for a treatment, when they undergo something, it will make changes in the body because it is hormones. So new hormonal therapies are there, but the main central theme is menopausal hormonal therapy, which is a recent advancement. Previously, we called it as hormonal replacement therapy. Now we call it as menopausal hormonal replacement therapy. Okay. So some people will have symptoms, some people will have no bothersome symptoms. It depends on each individual. So this is the evident update from NICE and from IMS. So it was an update in 2026. So these are the common changes which is happening overall the world, and this is evidence-based practice, which as a nurse we are now following evidence-based practice, right? So we'll go to the next slide, please. What is your take-home message? Assess should be symptom focused, risk-based, and patient-centered. That's what I was continuously telling from the first till now. So routine hormonal test is not that much, it's really unnecessary. Those who are having symptomatic treatment, you know that they are reaching some menopausal. So it's not mandatory that you go for an anti-Mullerian syndrome, ovarian function, ovarian test. Likewise, no, it's not that much needed. MTH is effective because it reduces the vasomotor symptoms. The route, dose, what is the choice of progesterone has to be managed, individualized. Cardiovascular, breast, risk has to be communicated. GSM is very, very, very important now. Sexual health, proactive questioning should be there for the patient. CBT and new therapies are there, which has to be effectively utilized. Regularly assessment and will help for high quality care. So the goal is not to prescribe a product for the patient. The goal, what I would like to suggest, is to improve the health, quality of life as an individualized care. Next slide. These are my references. Most of these are limited references. I have more references over here. If you would like to read more about it, it's there. Any questions? I have seen a hand raised in between.
No, ma'am, continue. It was a technical issue.
Oh, it was a technical issue. Fine. My key references are already here. And it's a thank you message in the upcoming slide also. We'll go to the next slide. Any questions? And if you would like to collaborate with me, my email IDs are given in the next slide. And my LinkedIn profile is also updated and you can contact me over there. And this is my email ID and my LinkedIn is also here. And anytime, any collaborations in research or anything, I'm happy to welcome. And if you would like to have any further sessions or also, I'm happy to do that. Thank you for your active listening.
Thank you so much, ma'am, for your precious time and in-depth knowledge that you have given to us by this topic.
Thank you.
And we are very grateful to you. We are very grateful to you that you have took out some time for us out of your this busy schedule. So
Fine.
I hope that this session was very, very knowledgeful.
Thank you so much.
Are the things that we haven't even imagined that in depth we could study this much that we have gained from you. So now I would like to request every student that there is a form shared in your groups, a post-test form. Everybody please open your class groups. There is a link shared by your respected coordinators of a post-test form submission. This will reflect how attentively you have attended today's sessions. So go through the form, give the answers, and you have 10 minutes time. Thank you. So I hope that you all have given the test. So as we all know that every beautiful journey has an ending. So similarly, we are also at our ending of today's webinar. I hope that this was very knowledgeful, very encouraging, and very much interested webinar that you all have attended about a particular topic of nursing, menopausal health, which is very important topic in our. So it's my privilege to honor a vote of thanks to SNA unit, SN College of Sri Ganganagar, in collaboration with TNAI Rajasthan State Branch,
And I extend my heartfelt gratitude to our President of T&AI Rajasthan State Branch, Dr. Joginder Sharma ji, for created platform to do such a program, and a heart warm thankful to our teachers, Dr. Sarita Rawat, Professor Manpreet Kaur, and our international teacher, Dr. Virgis. So it was a very honorful and privileged to be host of this event, and I extend my heartfelt thanks to everybody who directly, indirectly contributed in this webinar. So once again, thank you all. Have a wonderful day.
Good afternoon to all, one and all. Myself, Dr. Shakti Singh Soni, Vice Principal, SN College of Nursing. So now we are going to finish or complete our seminar, webinar, and I am very thankful to Dr. Joginder Sharma sir for providing a great platform us for enhancing and encourage the knowledge of students and our faculties. It is my privilege and honor to purpose vote of thanks to all the in the favor of international webinar on menopause health organized by SNA unit SN College of Nursing Sri Ganganagar in collaboration with the TNAI Rajasthan State Branch. First and foremost, I express my sincere gratitude to our estimated resource person, Mrs. Sarita Rawat ma'am, tutor at PGA Chandigarh, Ms. Manpreet Kaur, professor at Mira College of Nursing, Abor, Punjab, and Dr. Virginia Varghese, nursing educator at Oman, for thanking the time I share her to share her valuable knowledge and expertise on the concept and type of menopause. Your insightful session and certainly enrich our understanding and will be highly beneficial to our students and participants. It extend my heartfelt thanks to our to head and TNAI branch of Rajasthan. I am very thankful for their collaboration and support in making this webinar possible. A special word of thanks to all our students, faculty member, nursing professionals, and participants who joined us and contributed to the successful of this international webinar through their active participation. Thank you all of you.